In the early history of traditional Chinese medicine, the most revered diagnostic method was reading the pulse. Touching patients became a deadly risk for doctors during the infectious plagues of the Yuan to Qing dynasties. In an active outbreak, feeling a pulse required close physical contact that often proved fatal for the physician. Outbreaks of highly transmissible diseases like the pneumonic plague, a severe lung infection caused by Yersinia pestis, forced a total reevaluation of safe clinical practice. Without safely touch their patients, doctors required a non-contact method to track how a disease was progressing and whether their treatments were actually working. Under these extreme pressures, visual observation of the tongue rapidly developed into the primary method for diagnosing internal states. Tongue diagnosis functioned as a critical survival mechanism during these plague eras, providing an objective index of internal physiology without the risks of physical contact. The earliest definitive text on the subject, the Golden Mirror, contained only 36 basic visual charts for practitioners to reference. Later texts expanded this catalog to over 120 variations of color and texture. However, relying purely on visual pattern matching against historical charts is functionally inadequate for modern clinical complexities. Superficial color matching ignores the deeper data required to differentiate between severe, contradicting pathologies. For instance, a practitioner must distinguish true heat, a genuine inflammatory state, from false heat in emergency states, where exhausted resources push a patient's remaining energy to the surface. Achieving high-fidelity diagnosis requires a complete clinical model that bridges these traditional energetic maps with concrete microvascular anatomy. Understanding the exact physiological mechanisms behind these visual signs allows a practitioner to apply rigorous clinical deduction rather than simple pattern matching. The first major variable of observation is the tongue body, which governs the core vitality, physical shape, and overall color of the muscle. The color of the tongue body is physiologically dictated by these mushroom-shaped or fungiform papillae. Fungiform papillae are sensory structures rich in blood vessels. Vasodilation in these specific papillae presents visually as a red or purplish body, reflecting the microcirculation of heart blood. Conversely, vasoconstriction results in a pale body, indicating restricted circulation. The second major structural variable sits directly on the surface, the tongue coating. The coating is governed by an entirely different structure, the filamentous or filiform papillae. These thin, spiky structures provide texture. The coating forms from a keratinized membrane and cellular debris, representing stomach qi spreading to the surface. By strictly differentiating between these two biological structures, a practitioner can separately evaluate the microcirculation of heart blood through the body muscle and the metabolic health of stomach qi through the coating. Transitioning from microanatomy to macrosystemic mapping, the tongue serves as a scaled topological map of the entire body. This framework is the holographic projection, the concept that the tongue reflects the body's three metabolic zones, known as jiao. The upper jiao maps to the front one-third, the tip, corresponding directly to the heart and lungs. The middle jiao maps to the middle one-third, corresponding to the spleen and stomach. The lateral edges represent the liver and gallbladder. Finally, the base corresponds to the lower jiao, reflecting the kidneys and the life gate. Beyond static locations, the tongue also maps directional, energetic vectors of internal organ function, known as qi kinematics. Energy ascends on the left, moving from wood to fire at the tip, and descends on the right, moving from metal to water at the root. This holographic map provides a localized view of internal organ health, allowing practitioners to pinpoint pathologies and track the movement of internal qi in real time. The precision of this holographic data is entirely dependent on the physical mechanics of how the tongue is observed. The extension must be standardized. The tongue must be relaxed and kept flat, with the tip naturally pointing downward to accurately reveal the heart and lung zones. The most common patient error is forceful extension. Excessive force artificially engorges the tip with blood, creating a false redness that mimics upper jiao heat. Mechanics are equally strict when examining the sublingual collaterals, the veins under the tongue, which reflect systemic blood stasis. The patient must open wide and gently rest the tongue tip against the upper palate. A crucial error is allowing the upper teeth to bite down on the back of the lifted tongue. Mechanical pressure from the teeth constricts blood flow, causing the sublingual veins to artificially swell and thicken. This specific error frequently leads practitioners to diagnose severe blood stasis and prescribe aggressive therapies when the veins are merely reacting to physical pressure. Practitioners also employ a physical scraping test to check the rootedness of a coating. A coating with root appears to grow out of the tongue surface and cannot be wiped away, while a rootless coating sits loosely on top and indicates damaged yin or qi. Strict adherence to these mechanical protocols is the only defense against physical artifacting, ensuring the data extracted is pure physiological truth rather than an induced symptom. Even with perfect mechanics, a practitioner must actively filter out environmental and chemical artifacts that corrupt the visual signal. Dietary staining is the primary culprit for false coatings. Consuming milk or soy residue mimics the thick, greasy white coating indicative of damp phlegm, a pathological accumulation of viscous fluids in the body. Pharmaceutical interference also distorts the reading. The long-term use of certain antibiotics can strip normal flora and induce artificial black, gray, or moldy coatings. Improper lighting creates subtle distortions. A standard fluorescent bulb can shift a normal white coating into a false yellow hue. Taking a rigorous dietary and pharmaceutical history prior to examination is a mandatory calibration step. Failing to filter out this external noise leads to treating the patient's lunch or their medication rather than their underlying systemic pathology. To prevent omissions and chaotic diagnostics, practitioners follow a standardized observational sequence known as the main thread. This algorithm rests on 3 pillars: the body, the coating, and the sublingual vessels. The practitioner begins with the body, systematically checking spirit, color, shape, and movement. Next is the coating, evaluating texture and color to assess metabolic health. Jumping to a diagnostic conclusion based purely on color while ignoring structural data like shape or vitality breaks the logic of this algorithm. By combining an understanding of microvascular anatomy with the classical holographic map and enforcing strict observational discipline, practitioners can extract the high-fidelity data required to execute exact clinical interventions.